So I'm delighted to see so many of you here today. And I think I have to move the slide on. Hang on. Not that one. That's me. Sorry, I should have introduced myself. Sarah Cunningham-Burley. There we are. Welcome to everybody. I'm glad that you're here in the wonderful Usher building. Those of you that are not here for your working lives, and also welcome to everyone joining us online. I think some people outside and some people in the ether, so to speak. And this event is part of our event series called Usher Connects. So Usher Connects, and some of you may have been to some of our other talks and conversations, showcases how working with people, populations, and data, that might be big data, small data, quantitative data, qualitative data. Today, it's big data. How this can transform health and social care and our understandings of health and social care. So through bringing us all together to contribute to and hear experts talk, have panel discussions, and by promoting cross-sector networking, Usher Connects offers a chance to share, hear the latest research, and foster collaboration. So as I said, both across sectors and also importantly across disciplines. And this all helps us make our research impactful, both locally, nationally, and globally. So our event today will explore, as you all know, the future of health and social care data for research. And to do this in the context of Scotland and across the UK more widely. And we're going to hear from Professor Cathie Sudlow as she presents from her influential publication, the Sudlow Review, Uniting the UK's Health Data. So this will be followed by a panel discussion. I'll introduce the panel later, and audience Q&A as well. And I will tell you how to submit your questions a little bit later. First of all, some housekeeping. There's no fire alarm scheduled. And have I got to put the housekeeping slide on? Sorry, too many things to think about at once. No, the housekeeping slide. Housekeeping slide. Was somebody else forwarding these for me? Were they? No fire alarm. I think the exits are there. So here we are, very straightforward. And the bathroom, should you need them, and obviously just get up anytime you want throughout the afternoon, are just out here. Our programme, as I said, will be a combination of talks and panels, and you can submit a question, and we will open Slido up for questions after Cathie's presentation at the time the panel discussion starts. So you can start to hear the questions, but I will be asking the panel and then make your own contribution. So to do that, and this is not the only chance to log into Slido, if you've got a smartphone with you, you can access using the QR code or use the number there as well. I'll leave it up for a moment or two. So you can submit questions and add your name to them, or you can submit anonymously. But the slide will come up again, and then it will keep coming up so that you can keep asking your questions. So now it gives me great pleasure to introduce Professor Cathie Sudlow, head of the Usher Institute, director of the Usher Institute, head of the School of Population Health Sciences, same person, and also director of the UKRI Adolescent Health Study. So this is a new and very exciting longitudinal population study and data platform that will focus on the critical biological and social developments that occur during adolescence. And it aims to follow 100,000, I think that's right, participants aged 8 to 18 for a period of 10 years. So a really robust longitudinal study. But throughout her career, her research interests have been firmly embedded in big data, and she's played leading roles in many large-scale, collaborative, open science initiatives so that we can better understand the causes and consequences of health and disease across the life course. So, of course, this made her an ideal person to lead the independent review of the UK-wide health data landscape, what's come to be known as the Sudlow Review, Uniting the UK's Health Data a huge opportunity for society. So we will be hearing about those opportunities today, debating them, analysing the risks and benefits. So Cathie will start our discussion today with a brief presentation from this, with specific reference, as I understand, to the Scottish context. Thanks, Cathie.
Thank you very much, Sarah. Am I mic'd up? Can people hear me okay? I have a quite irritatingly loud voice, so I probably don't really need the microphone anyway. So for those of you who haven't heard me speak about this review before, this is a whistle-stop tour. The first few slides will give you a kind of context. I'll then show some examples of what good looks like, and comment that those examples are all too few and far between. But that's the time to go to sleep if you want to have a little nap, but then wake up for the last 3 slides where I'll kind of refer a little bit more to the Scottish context and what the challenge is for us and opportunities are for us up here in Scotland to play into this evolving world across the UK. So this review was commissioned by the Chief Medical Officer for England, Chris Whitty, and the UK National Statistician, who at the time was Ian Diamond. He's recently stepped down from that role, and NHS England. So it was commissioned in a sort of English context, but very much the remit was to cover the UK-wide landscape, which suited me really very well. So the ask was to do 2 things. The first was to map the linkable health data sets across the United Kingdom, and I'll come on to in a moment what my, and indeed I think the accepted definition of health data is, but it's really quite broad. So data relevant to health, which doesn't just come from the NHS, of course. And then secondly, to outline some of the key barriers to the sharing of or broad access to those data for uses for public benefit, a very broad set of uses, of course, whilst maintaining security and privacy, and identify some of the solutions to overcome these. So the review involved doing some stuff that I was fairly used to, which is like reviewing stuff and writing about it. That's the standard academic behavior, but also doing some things that I was less familiar with, which is like making policy recommendations that could actually be implemented in the context of a UK government setting. That was very interesting and a challenge. And I had fantastic support from colleagues at Health Data Research UK, but also consulted with hundreds and hundreds of people and organisations from the NHS, from academia, from industry, from charities, and importantly, patient and public-facing organisations and professional ones as well, to kind of build the picture. So I'm going to cut to the chase and outline for you the key points which I really encountered during those discussions and during reviewing this space. So the first is that, of course, we as health professionals and as researchers and as people use health data about ourselves and indeed about others safely every day to improve people's health and lives. It is the essential substrate of delivering, one of the essential substrates of delivering healthcare and research about healthcare. And actually, if you look back over 10, 15 years or so worth of surveys, focus groups, discussions, etc., and Understanding Patient Data has a really good website which summarizes a lot of this material. People are very supportive of those sorts of uses, not only for their own benefit, but for the benefits of others. And it's important we don't forget that. Not every single individual thinks it's a wonderful thing, but the vast majority of people across all age groups and all sectors of society are very keen on this being done. They want it done well, they want it done responsibly, they don't want to be exploited, and they want to know what's going on, but they want it to happen, and they expect it to happen. The UK is in a really great position. We have very abundant sources of health data that come from multiple different sources, both from the NHS and from outside the NHS, that are part of this picture. And the important point here is that the really important insights come from not the use of a single data set or a single source, but when different sources of data are linked together. That's when we see really transformational magic happening at whatever scale that linkage is being done. So linkage of different data sets together at individual level is incredibly important. We know through our own experience that there are many obstacles and delays to that happening well, and particularly to it happening fast. And fast is often what's needed. It's not always what's needed, but timely insights are often incredibly important. And at no time was that more apparent in recent experiences during the pandemic, when some of these obstacles and delays started to be overcome. But actually, if we'd been across our nation, both in Scotland and across the UK, in a better position going into the pandemic, it would undoubtedly have made a difference to the way in which we gathered and were able to act on intelligence from data sources during the course of the pandemic. And I believe the outcomes would have been better as a result. So these barriers arise because we have complex and inefficient systems for access to and use of data. And decomplexifying and simplifying systems does not mean making them less safe. Indeed, I would argue precisely the opposite. The easier a system is to understand and navigate, the easier it should be to explain, understand, and use well and responsibly, and the safer it is therefore likely to be. These barriers prevent or delay very important analyses and research about health conditions affecting millions of people across our country and indeed globally. And so not doing this well or well enough is really letting people down, people and their families. And so only by recognizing the UK's health data as part of our critical national infrastructure can we really start to get this right. Recognizing it as such, investing in it as such, and creating processes that are appropriately rapid and streamlined to allow this to happen. I've gone a little bit too far there. So just a brief tour of what I mean by health relevant data. So we have administrative data about us that is collected every day in all sorts of sectors. Some of those data that come from the NHS are collated, brought together into national data sets. You'll be familiar with those in Scotland. Many of them are called SMR, something or other, different numbers. And they refer to deaths and hospitalizations, various other things. There are national collections of data from general practice as well, and about medicines and so on. And these arise in all 4 nations of the UK. Before the pandemic, Scotland had a good, safe way of sharing and linking those types of data nationally. It wasn't perfect, didn't work as quickly as we would all like, but at least it existed. So did Wales. England was on the back foot, but has caught up during the course of the pandemic, and perhaps slightly unfortunately has rather too many now systems that enable access to data at scale through secure data environments, but it's much better than it was. And so we have this network of national data sets held in secure data environments across each of the 4 nations of the UK. And then we also have more complex granular data sources that tend to be held more locally or regionally. Imaging data, free text data, and laboratory data are good examples of those. I would say the trick here that we'll need to work on is making sure that those can appear as if they were national. So create out of them national data assets. There are a number of different routes to that. Scotland's done a job of that on imaging, as I will come to later. And then beyond the health service itself, of course, we have many other sources of health relevant administrative data that come from, for example, the census, education systems, disability systems, income systems. Some of them are UK-wide, some of them are national, and some of them rest more at local authority level, and therefore need some work to bring them together at whole country level, which I think is the unit of activity that is of most interest and relevance for many, many questions. So also beyond these administrative structures, there are data that come from our own selves. We create lots of data about ourselves through personal monitoring, smartphones, watches, club cards, etc. There's environmental data from weather monitoring and from air pollution monitoring that goes on at national level across the UK. And then as a research community, we generate research data through trials and large scale and smaller scale clinical observational studies. In each case, and I've given you some examples of those on the slide, in each case, all of these data types and the data sets within them are great, but it is by linking them together between the boxes on this diagram that we really start to see fantastic things happen. And, you know, for example, research generated data trials can benefit hugely from the ability to recruit people based on their administrative data footprint. We can use such data to rapidly identify people who would be eligible to be invited to take part in trials and should be given the opportunity for large-scale population-based and large-scale and smaller-scale clinical research studies. So a few examples now. So here is what these are the sort of examples that are large scale that I think illustrate this type of capability particularly well. Many of them come from the pandemic, and where it's appropriate, I've provided some Scottish flavored examples. So this is one that only became possible during the pandemic. Scotland has its house pretty well in order in terms of national medicines data capability, and brought that to the fore during the pandemic. England caught up, and so did Wales. And so it became possible to do this 3-nation study of the course of dispensing of medicines during the course of the pandemic. This example shows the picture for cardiovascular prevention medicines. You can see this big dive in medicines prescriptions early on during the first lockdown, which started to recover but did not completely recover. A bit of modeling shows the number of heart attacks and strokes that we might expect to have occurred as a result of people not getting new prescriptions and collecting prescriptions for medicines that you would otherwise expect them to be taking. About 500,000 people are so affected, and some thousands of events during the early months of the pandemic that might have otherwise been prevented if this had not happened. So these are highly policy relevant studies that come out of the use of data that already exist, but that until they are in safe places, accessed by researchers or analysts who know how to make sense of them, they're virtually useless. So why do we collect them if we're not going to use them to derive this sort of intelligence? And similar studies were done to look at the course of prescriptions of sodium valproate during the pandemic. In my view, this should be business as usual for all medicines, so that the MHRA, for example, can understand what medicines are being used for, and NICE can understand whether guidelines are being adhered to very straightforwardly. So here we have another example. This is a 4-nation study, the first of its type ever, and it was performed during the pandemic using the types of resources and data infrastructures that had been built up during the pandemic. In this case, this is work that was led by the Usher Institute in partnership with Health Data Research UK, to look at what proportion of each population across the 4 nations was under-vaccinated in comparison with JCVI criteria for what would be a perfect vaccination schedule in each of the nations of the UK. So vaccine uptake was pretty good early on, and it sort of dived down a little bit as people became a little bit more vaccine fatigued, or stories started to circulate about some of the adverse effects of vaccines and so on. And so we have a job to do in terms of keeping up on that one. And it also, because of the individual linkages to other data sets, was possible to look at things like what drove under-vaccination, what the risks were in different groups, and what the consequences were in terms of prevention of severe outcomes. Some other examples, this time of, if I skipped ahead again a little bit. Yeah, this time of one of the Scottish successes. So this is Scotland acting as a part of the UK, bringing its national imaging assets together and enabling their linkage at whole country scale to other sources of health data. This is globally a really leading resource. There is nothing like this anywhere else in the world. There are big imaging collections, but not that are disease agnostic, that draw lots of different types of images together and that enable their linkage to other types of data as well. And see Will Whiteley sitting here in the audience. He's one of the scientists who's now working with others to use artificial intelligence to help predict subsequent dementia risk, because these are longitudinal records. They go back at least 20 years. So in this case, in the case of imaging, 10 years, to enable these types of predictive models. And this is the tip of the iceberg. The world is one's oyster with respect to the types of questions that these resources can be used to address. And the population deserve to see, I think, really great uses of the data that they have been involved in the collection of. So here we have some examples of linking across sectors. So in this example, and Wales do this very well, which is why I've used a Welsh example here, the linkage of education data to health data has shown us the consequences of school absences in later life in young people, adolescents, and the consequences of neurodevelopmental disorders on later life health outcomes as well. But also we have some Scottish examples. So this example illustrates 2 things. It illustrates that we can do this sort of thing in Scotland. It's one, it comes from colleagues in Glasgow. But I'd like you to notice, and it's looking at social care data linked to health data to enable us to identify the people with dementia in our population who are resident in care homes. As you know from the pandemic, an incredibly important population to be able to identify, and we couldn't do it at the start of the pandemic. We can now because of the work of these people. But note that they were working on data from over 10 years ago, and this work is still not published. So this sort of stuff takes far, far too long. This should be something that we can concertina into several months, not several years, and that should be our ambition. Something's happening here in terms of advancing the slides. I think it was happening to Sarah as well. So we also have the potential to use routinely collected data to enhance large-scale clinical trials, as I alluded to earlier. You'll have heard of the recovery trial. It's used routine data to identify outcomes in people without having to go back and ask them each individually, all 50,000 of them, whether they've had a heart attack or whether they're dead or not, because obviously you can't ask people that question. You do it through linking to death registers to find that sort of information out, and it's very efficient and effective. The NHS Gallery trial of a blood test for the early detection of multiple cancers could use central NHS data to invite millions of people to enable over 100,000 to be recruited to that very large-scale screening trial. And closer to home, the Aspiring trial of the rarer form of stroke, brain hemorrhage, is working with national resources both to identify participants to take part in this trial, but also to follow them up and identify their outcomes. So huge potential there, but not nearly enough examples of that happening. And then in the UK Biobank, which is one of the best known examples of a large-scale observational research study, again, linkage to data from outside of that study, from routinely collected data within national NHS systems, has allowed fantastic insights to emerge. And there's a few examples on this slide of the use of accelerometry linked to outcomes data to identify what the real impact of physical activity is. And things are getting into practice. So NHS memory clinics are now using the types of data analysis platforms that have been developed in UK Biobank for accurate diagnosis of dementia. That was critically dependent on linkage to routinely collected data. And the same applies to prediction models of disease. So you can see the types of research that are enabled by this sort of linkage. So these are some great examples. They demonstrate what's possible. They are actually, though, in reality, far too few and far between. They are not embedded in our business as usual. And each of these has been far too much of an effort to really bring it to fruition. And it should be something that we have embedded in our business as usual. That does not mean making it unsafe. It means making it straightforward and streamlined. So we have too much complexity, too much friction, and too many gaps in our systems. These are the recommendations from the review for system-wide reform. So firstly, a coordinated strategy for health data is our critical national infrastructure. That involves organizations working together, pointing in the same direction, losing their egos and losing their kind of natural human tendency to build their own empires, but actually being willing to share empires and being willing to share infrastructure across different organizational boundaries. That applies across countries and it applies across major national organizations, NHS, academic and beyond. I've talked about establishing a national health data service, and some key components of that include some key data sets, particularly general practice data, which we heard again and again during the work for this review, was a key need, where there are solutions, too many solutions, and none of them does everything that's required. So we need less solutions, but more capability within those solutions. That's probably a general message, but it's a particular message for general practice data. And of course, those things need coordinated engagement with key groups, patients and the public in particular, and health professionals as well, but also standardized approaches to data access processes and proportionate data governance. Doesn't mean everyone has to be doing exactly the same thing, but we need a rule set so that people can follow the same principles. And a UK-wide system as well for standards and accreditation of secure data environments, which it's a little bit like the Wild West at the moment. There's lots of different flavors. They are starting to coalesce around some standards, thank goodness, at last, but this needs to continue. So Here's the Office for Life Sciences summary of the review. I thought they did a really great job of putting it all on one slide. I wish I'd managed this myself, but anyway, never mind, they got there. So it's just a very nice slide, and you can see that with an ambitious and joined up strategy, then the kind of the way in which they've captured my 5 recommendations in 4 neat bullet points, but also what the sort of untapped potential of UK health data is from an OLS point of view. And finally, it's been a great pleasure and actually something of a surprise to see a review which I thought would sit on the shelf and gather dust, as these things tend to do, be quite well received across various government departments, most of the relevant ones. But also, and I think this is partly serendipity to do with when it landed, aligning with the government's economic growth agenda, their plans for the health system, and the opportunity to inform the life sciences sector plan and 10-year health plan for the NHS. And I only take responsibility for the bits you like and not the bits you don't like of those. So there was this announcement in April, which was done while the Prime Minister was in a car factory talking about cars, but he squeezed in a little bit of data to say that the government, in partnership with the Wellcome Trust, were going to fund the sort of service that had been suggested in the review. So that's a good thing. Feels like a tick in the box, but of course it leaves a lot left to actually do in terms of delivering it. So here are the key features as it's been laid out by government. This will be some sort of government-owned company operating a bit like Genomics England across the UK. So different from Genomics England in that regard. National does mean UK-wide. They've been very clear about that. There are some core must-have whole population national data sets. Scotland has most of these. They need to be available quicker, but general practice needs to be added in an accessible form for the whole country. And I realise the challenges there, looking at Carol. And there are some underpinning principles, of course, which I've alluded to already, so I won't repeat those. And finally, some opportunities for Scotland. So the first thing to say, I think, is that in Scotland, we need to focus on the things that we can do together across the whole country. That doesn't mean that we lose regional specificity and local control and local expertise, but we need to bring that together into a national whole. Scotland's too small a country not to do that, and we can't afford not to do it, quite frankly. So fragmentation and duplication are not really acceptable. We can't afford them. Accessible GP data at national scale is one of the crucial ingredients. When have you heard me say that before? And of course, it means alignment and full interoperability of regional and national data platforms. And some of the panelists who are talking today will speak to that with far more sophistication than I can. And we need to share across organizations. We also need to realize some of our key assets and capabilities that I think we're kind of sitting on and not making the most of. So we have experience that goes back a long way in Scotland. We shouldn't be complacent about it, but we have been doing this longer than any other country in the UK, this sort of thing. We need to keep updating, and we need to keep up to speed, and we need to continue to be a vanguard country and a demonstrator. We also have longitudinality of records. They go back to the 1950s in some cases. So that's very important. It's really useful for some types of inquiry. We have great capability in GP data. We've had a little company called Albasoft operating out of Perth for a long time, which can extract records from all the GP surgeries across Scotland and bring them together and handle them safely and well. And now at last it's been acquired, this company, by National Services Scotland. That's a fantastic step forward, and it will help us on the journey towards GP data across Scotland. Because other countries are getting their act in order as well, including who are on a path to sort this out. So let us not be left behind. The Scottish medical imaging resources I've referred to, they are fantastic. They are globally leading. We should be making absolutely the most of those. We have a fantastic neonatal blood spot archive collection over in Iron Mountain near Glasgow, which is potentially linkable to national health relevant records. There's quite a lot of work to do to realize the ambition of actually making that into a viable, usable resource for research and for the NHS and so on. but I think it's hugely investable and would attract inward investment like no tomorrow if we could bring it to fruition. So fantastic potential there. And we also have amongst the best national offerings in terms of medicines data, both from in hospital and out of hospital, which I think give us a great position for medicines and safety monitoring. So those are a few examples of some of the things where I think Scotland has something very special. And finally, we need to address the biggest risks as well. And people will have different views of what these are, but I think we are at risk in this country of complacency because we've been doing this sort of stuff for so long. We have to look around us. We have to see what others are doing well. We have to be willing to learn from others, but also continue to be a vanguard, stay on the front foot, demonstrate well, and be willing to then share what we do well with other countries who can help us to scale that to larger than 5 million size population. And then I think our other biggest risk is actually emphasizing risks over and above benefits. So this is an area where people worry about risk and liability a great deal, but they sometimes forget to worry about what happens if we don't do anything. And if we don't do anything, we'll go into the next pandemic or the next global health disaster without the tools that we need to really be able to face it as well as we should. And I'll stop there. And sorry if I've spoken a little too long. Thank you.
Thanks. Thanks very much, Cathie. We're going to move into discussion, but you outlined lots of the sort of potential and opportunities, obviously also raised issues around barriers and risks. It made me think of something kind of quite transformational, really, in terms of myself and all of us who are patients, service users, who will be at different points in our lives. So we're there in all those data sets one way or another. But it has transformed our relationship with research. So really, you're actually talking about a research-led healthcare system from policy level right down to service delivery. And that requires very different sets of relationships, expectations, and responsibilities on all sides. And so I think that's something really fundamental to consider. And then when you talked about the UK government's policy for economic growth also made me think that fundamental to that is a healthy population. So I think when you talked about social determinants of health and using the kind of wider administrative data linking to health, then the real potential there for public health and good population health is something to really think about. But I would say that because I'm a sociologist. I'd like to introduce the panel who are now going to come up into the front seat. While I do that, I need to do something else. I'm going to come over there now. So on the row on my left, but on my nearest left is Roger Halliday, who's CEO of Research Data Scotland, so knows all about all of our data, but none of it identified. And then next to him, Cathie Harrison, who's here in Usher as the program lead for Datalock, so one of the key new, highly complex research data environments that Cathie was talking about. And then to her left, Christian Cole, who's reader in health informatics and co-director of the Health Informatics Centre at Dundee. Cathie, obviously, you have met already. And I'm now going to put up, does this work with me doing it, or do I have to be over here? The Slido thing coming back on again. Minor technological challenge. Once it's up, and you can do this while we're talking, the Slido QR code will come up again, so you can put your questions in. These, many of you will have used this before, but if you haven't, you can like a question, and then we can kind of see which ones are really popular. We obviously won't have time for all the questions, I'm sure, but Stuart Dunbar here is going to prioritise them, but I'm not telling you how. But there'll be various ways, and then he's going to signal to me which ones are being shortlisted. So it's all a little bit sort of techno-complicated, but I'm sure it will all work, and there will therefore even if your question's not asked, there'll be a chance for informal questions afterwards, which hopefully you can stay for the refreshments at the end of the session. And there it is, it's working. Well, I'm going to grill the panel first. But first of all, they're all going to have a chance to, for a free text opportunity to start the discussion off. So we'll start with you, Roger, and then go down the line.
Thank you very much, Sarah. And yeah, for those that haven't heard about Research Data Scotland, we've been established by Scottish Government to transform the way that data for research is used here in Scotland, to make things safer, faster, simpler for researchers to do research in the public good. And I suppose my background's in data and analytics in government, where I was the Chief Statistician and Chief Data Officer there, and I always saw the big problems that we had in Scotland that we were addressing, like child poverty or climate change, being very complex, multi-sectoral, but the data being collected in silos within schools or within the police or wherever, and actually the ability to bring that together is the evidence base that's required in order to be able to tell what options, how effective are policies on those complex challenges. So that's what really drives me, is creating the conditions in which organizations that hold those data trust people to be able to bring that together securely and use it in the research and public good. Now it's clearly tricky. There's tricky elements of that, as Cathie's outlined, in getting that right balance between what's acceptable to the public and what's expected from the public, and what's actually technically possible in terms of the processes and steps that you can make. But I think we're making real progress here in Scotland towards a single route into data here, working alongside Cathie and Chris and other colleagues here, because we've got fantastic data. Looking around the world, I think we're really blessed with the volume of and the depth of data that we've got. We've got fantastic expertise across our Safe Haven network and curation of data, and also clearly in the research community. And we've got the ability to turn that, given the scale that we're in Scotland, to turn that research into an insight into changes on the ground in terms of legislation, policy, and services. So I think we're at a potentially real exciting place, and delighted to be part of that.
Okay, thank you, Cathie.
Thank you very much. Hi, I'm Cathie Harrison. I work here in Usher, in this beautiful building. I look after the DataLock programme, which is one of the regional safe havens that Roger mentioned. DataLock represents South East Scotland, so that's a population of just short of 1 million people. We have a role to source, link, curate, and de-identify primary, secondary care, other health data, and create extracts to make them available within our trusted research environment for approved researchers. That's our role. And that's really what drives my interest in terms of some of the things that Cathie talked about, in linking population scale data with some of that regional data that represents all of the touch points with the health service within that combination. And I think that combination really gives us the opportunity to think about the health system in all of its complexity as a complex system. And we couldn't do that at population data without that regional data. We need to be able to link the two. So really interested in diving into that in more detail. I think we also should be thinking about what that means from a social care, community care perspective, where data is much more scarce even, much more difficult to look, much less digitization in that space, but it is a particularly complex part of the care system that we need to understand, and it's going to be critical if we start moving towards that preventative care ideal that we talk about so often. So that's another thing that really interests me. And I think the third area for me is how do we think about the pace at which public perspectives are changing around data access? So as a data service, we have a responsibility to understand what people's perspectives are of their data being used in this way, and responding to that in terms of how we operationalize some of those ideas. So really interested in that as well, hoping we get into that a bit with the panel.
Thank you.
everyone. Firstly, thank you for the invitation to be here and to speak to you about what we do. So I'm an interloper, I'm from Dundee, so I've made the long journey south here today. And I'm a health informatician, I'm an academic researcher or health data scientist, and my particular interest in this space is around how do we make health data more useful, more readily available through data infrastructure, through computational mechanisms, whilst maintaining the sensitivity and the security, and making sure that we can do the research we need on the data that's available to us for the benefit not only of researchers but also clinicians, people who operate these systems that manage the data for us, and lastly and most importantly, the public and the patients who benefit from this work ultimately, you know, of what we're trying to do to improve people's lives. And as one of the past reviews that talked about this, you know, data does save lives, and I strongly believe in that. And I think we need to work out on how can we best make that happen. Now, the issues we have are that, you know, research and data research is becoming increasingly complex. We can do much more now than we used to be able to do, from data across the whole spectrum and the whole gamut of things that are available to us, as Cathie really well presented here. You know, things from your club card right to your medical records and everything in between, from, you know, birth to death, is potentially available to us. But that needs infrastructure, that needs computational capacity, it needs to have skills that we don't necessarily all have in the same place or in the same pockets of capacity. And in Scotland, we have that across the board, across the country, but bringing that together is the challenge. And I think that's what we are here to do, and that's what we can do. And through the Safe Haven Network, the Cathie is done part of the data law. At HIC, we cover east of Scotland, so that's Tayside, Fife and Forth Valley. And we have access to secondary care data and all aspects of data like that. We'd love to have more access to more data like GP data. And so my research areas at the moment are particularly around funded work through the Day UK activities that are being run at the moment. So that's looking at UK-wide activities around trusted research environments, which is another name for a safe haven or an SDE, that these names are kind of bandied around and changed over time. And, you know, how can we federate data? How can we federate analytics? How can we standardize the environments, or you know, have a common specification around that? So I'm leading on a piece of work called Sartre, which is looking at standardizing architectures for TREs. And that's been picked up really well across the UK, and we're trying to develop that further to turn it into an accreditation so that things are commonly usable for operators, for data custodians, and importantly for researchers. So you don't move from different organizations and then have a completely different environment to work in. And you have to relearn all the skills again. And I think that's an important area. And along with things like AI, that's all coming to the fore, I think it's really important to have a common infrastructure across the country, across Scotland particularly. And I think that's a really important area to be. Thank you.
Right, thanks very much, all of you. Cathie, I'm sure you'll have an opportunity to come in again shortly. Everyone, remember to ask your questions, because I've planned some questions which the panel have had in advance. But of course, I now actually want to ask a load of other questions. So please ask your questions, because no doubt you will have thought of some of the same ones as me. I've always found the data save lives thing just slightly grating, or just not quite right, because of course good data and the right data, well used, that then influences policy and service delivery, may well save lives. What kind of data floating around itself is not really going to do that. So just saying, and that might raise issues of public trust. That's my first question. Obviously, public trust is absolutely key to socially and ethically acceptable generation of and use of health data. So I want to ask the panel, well, maybe not all of you, what you see as the main challenges in relation to public trust. What lessons have we learned from where things have really affected public trust in the past, and how are we doing in Scotland in the context of public trust, and actually how do we know what we're doing in the context of public trust? Roger, maybe you want to go first?
Yeah, I'd like to. So obviously you kind of asked what some of the main risks to public trust might be, and I would suggest that one of them is around the feeling of choice that people have in the use of their data. And in particular, it's important, sort of context for people that in England, the legislation gives choice, the setup gives choice to people about how their data is used. In Scotland and in Wales as well, that choice is there. And I suppose my view is that we want good science to happen, and that if people decide to opt out of the use of their data, then that can affect the bias that exists in the data and can lead or gives the risk, I guess, of bad science. So my view is that we should try to take this head on in terms of making sure that we're demonstrating the trustworthiness of all we do, and in particular to make sure that that people's data is kept safe, that it's only used for research that's in the public good, and that it's really clear about what's happening to the data. So it's quite transparent about that. But I think this is a particular issue around opt-out because if we're coming towards a UK-wide service, like Health Data Research Service that Cathie mentioned, that if we've got different policies around this in different nations, then that could well lead to public perceptions changing around their feeling of choice, and that it might be something that we'll need to come back to what our policy is in Scotland.
So that also kind of speaks to how we engage with the wider public. And I know, Cathie, in Data Lock, you've had a really strong program of involving the public throughout the development in relation to governance in particular. So if there is a transformation in the relationship between us as subjects, whether we're patient service users or research participants, challenging something like the opt-in and opt-out side of that is something that we would need to think about. So maybe talk a little bit about how you see what we've done well in relation to public engagement and what the future for that should be as we develop the kind of recommendations that Cathie's review has come up with.
I think it's a really important question as to how we do that. We, I think, have a responsibility, certainly as data services, to understand people's perspectives. I think people's perspectives are changing very quickly, and I think that means we need to do it more systematically. We can't go out and ask opinions on one day and expect those opinions to be the same in 6 months' time. And I think it depends very much on social influences, social themes as to what people's perspectives are at any one point. That really has challenges for us. How do we operationalize our responses to that input if it's changing, quite so dynamically? We have found that actually there is a need to go out and do this very deliberately, to really be targeted in the conversations that we're having. I think there have been some unrepresented groups, particularly with social media being so loud. There are a lot of quiet voices that, unless you go out and deliberately look for them, are missed. So I think, again, we have a responsibility to do that more systematically. It's challenging because it costs money and takes time. And actually, we have been funded luckily to be funded through research programs and through a lot of the Dare UK work to go out and seek opinions from the public about data access and questions of data access. And I think the opportunity then is to think about how does that influence the controls we put in place around that? How do we think differently about public value of research projects and something that's very subjective? So I think that's really where the opportunity lies now, is to make this more systematic, and that includes thinking about how we fund it more systematically, even to the point of understanding what a baseline opinion might look like and going out and seeking that opinion again and again and over time. So I think that would be my view on how we could go forward with this.
Yeah, it has to be longitudinal and truly participatory, doesn't it? and well resourced. So points really well made. We've talked, I mean, throughout the afternoon so far about the opportunities as well as the barriers and risks of a UK-wide approach to secure, trustworthy data environments. So, Christian, I'll go to you next, and Cathie, I'm sure Cathie Sudlow and the rest of the panel will want to chip in. What are those opportunities and risks as you see them? Some examples, and what are we unable to do now that we will be able to do should we have a unified health system? Talked a lot about issues around sort of underdiagnosis and undertreatment, but I would have thought the opposite is also an equally problematic area, overdiagnosis and overtreatment, if we're thinking about efficiencies. So anyway, not going to answer the question for you, sorry, but I almost did.
So yeah, I think clearly the opportunities are very clear. You know, having more access to more data at different levels of granularity and with over a long period of time, and with all the aspects that impact on people's lives, depending on what their conditions are, whether it's a health condition or a social care condition, and trying to do those rich levels of research that we all want to do to be able to improve and make public benefit to the research that we do on health data and these really important and sensitive data sets that we have access to. I think that's the real goal here, and that's the opportunity that we need to do and try. How do we make that more efficient? And like Cathie says, it's not about reducing the security and the safety of it and the level of oversight. It's about, you know, how can we, you know, instead of snaking through all these different forms and things like that, you know, is there a single way to do this once and for all for each project as needed? And I think there's great opportunity and there's huge growth in this space at the moment. And I think that's part of the risk, because there is the risk of siloing, of repeating the wheel and trying to do this thing in your own domain because you think this is, well, because it's important to you, so you think I'll build this because it's going to be really good. I think there's a lot more to be gained by working together to commonly solve these problems that we all have, and do it once, and not do it once for cancer and once for genomics and once for dermatology and, you know, all these other things. You know, data is, I wouldn't say common. I think data in Aberdeen is very different to data in Cornwall, and that's part of the problem we have to deal with. But how we deal with those, I think, is an opportunity to work together to solve these problems together once, and then that'll help all our research be much more efficient and be able to answer the questions that we want to answer a timely manner, not spend 10 years curating your data. You create your data once, and then you can answer your question in a few weeks or a few months, and not spend your time on the boring stuff that I love doing, and I want to do that for everyone else. And so we can all work together on that.
Certainly kind of real-time use is going to be so important in terms of the health service. Cathie, anything you want to add? If not, I've got some great questions from the audience.
Yeah, maybe just briefly talking about some of the challenges which it would be nice to be getting onto. So we often, can people hear me? Yeah, we often talk a lot in these types of forums about the issues of access, because because the issues of access are often the biggest challenges. During the pandemic, a lot of us actually were involved in major what felt like transformational opportunities to access data at a scale and diversity that hadn't been accessed before in a range of different ways. And then you move into the realm of other challenges. So one of them Christian's referred to, which is this big curation challenge. So when you have lots of different sources of data, you suddenly realize that, oh my goodness, there's billions of rows of data here. How am I going to run my analyses? How am I going to handle that? And you need really well organized, systematic approaches to curation, which generally take up about 80% of any project. And it's the Christians who do all of that sort of stuff, who we should be incredibly grateful, but where we have to value the role that the team plays. So this becomes a team sport. So the challenge of recognizing the importance of teams and the data curation challenge, which Ben Goldacre spoke about a lot in his review, I think one really important area to recognize. And then the other challenges that come where we particularly where you start to do more complex analyses and into AI, where you've got compute-hungry algorithms and analysis paradigms that people want to be able to run, where then it becomes also a social-cultural challenge. So you need to have a workforce that both knows how to run these types of algorithms, but knows how to scale them to beyond 5 million to maybe 50 million individuals, where you need to think very carefully about how you run these analysis paradigms efficiently so that they are ecologically, environmentally responsible, as well as responsible in all the ways we've been talking about. Those are some of the challenges that I think are really enticing, that are being grappled with. It would be very nice if those were the main challenges we were now addressing rather than the access ones.
But they're intertwined, aren't they? So we have to think about those really big challenges, the ecological ones, workforce, expertise, quality assurance throughout the whole process as well. So thanks everyone for the questions that are coming in. Thanks to Stuart as well. So two kind of interrelated ones really to do with sort of the privatization of healthcare and fears about the commercialization of data. So any one of you can answer them. So there's two questions. I'll ask them both because there's an interrelatedness to them. So we talked about challenges of the sparsity and the scarcity of data in the social care sector. But there's increasing privatization in the healthcare sector as well. It may or may not be well digitized. I don't know, with patients choosing to go private. That's likely to be an area of growth over the years ahead. So what happens there? How's that going to integrate with this? And then the other is a question about the fears about commercialization of data. So for example, the involvement of Palantir. Are these fears ill-founded? And anyway, how can those fears be addressed? So I don't know if anyone can put your hand up if you want to answer the question. Okay, Christian.
I can start. In terms of the industrialization, I think industry is already involved in healthcare, massively. They build the equipment that runs a lot of the things that we do, and collects the data that from MRI instruments or from X-rays, So I think involving industry in healthcare is already there, and it's inevitable. And so, but we have mechanisms in place for managing those relationships and providing and doing work together that's mutually beneficial, and particularly beneficial for patients ultimately. And I think we can do that with our TREs or safe havens that we have, or SDEs, that we can provide access to limited amounts of data for the purposes of the research, for the purposes of the particular area or domain that we want to look at together with industry. And I think that is an overall benefit. But we can control it, and we can manage it, and we can work those relationships. Historically there was an attitude of providing data to industry, but I think that's very much changed, and it's now about providing controlled access for a limited period of time for explicit projects. And I think that is a safe and secure way of managing that relationship. And I think that is a way that we can do that. And I think there are benefits in that. There are risks in everything, but I think we can manage those risks.
Okay.
I was just going to say, we did a piece of work within Datalock looking at public perspectives around different data use, and that considered academic researchers in the UK versus academic researchers internationally. It considered commercial access to data. It considered AI research with people who are not familiar with healthcare data. And in all cases, the public was supportive, majority of the public was supportive, but actually what they were asking for was different controls and different considerations of public value for each of those groups. So I think saying, yes, we want to support commercial access to data, I think is a sure thing. The question of how do we do it and what different expectations we might have around safeguards we put in place is where we need to put our focus. And I think it's really interesting, you talked about risk emphasized over benefits. I think this is one of those examples where we do often think about the risks. And when we talk a lot about risks, it encourages organizations to look inwardly and entrench themselves in an organisation. And I think that's particularly true of the NHS or institutions that have been around for a long time. So I think it is up to us really, certainly in the data infrastructure world, to be pulling people out of that to think about the benefits and then think about the safeguards and the public expectations around how we do it, not whether we do it.
Yeah, okay. Roger, did you want to add?
Not too much, because I think I'm just going to reflect on some of the public engagement work that we've done relatively recently with industry. It was quite along those lines, and I guess there's two. The message that we got was, yeah, the public supports in general access to data where it's in the public good by industry, but subject to in particular a couple of safeguards. One was around transparency, so being clear who's funding what, who's accessing what, and what's expected to come out of it, and actually was that actually realised, and what happened both on the commercial side and on the public benefit side. But also there's something about the motivation of companies as well, just making sure that we've got existing checks on the motivation of researchers, but I think what also came out was ensuring that there's somewhere within the setup of the organisation that there's a public good motivation for an organisation, and we're working and doing a range of engagement with help and support from many people in the audience at the moment, with the owners of data, with industry, and with the public, to try and set out what's a practical way forward with to actually realise some of the benefits that we're talking about here.
Yeah, certainly my own work around data linkage has kind of supports that. There's not a blanket commercialize and a complete recognition of the importance of industry in health innovation development and delivery. I think some of the challenges are around potential lock-ins in terms of provision of algorithmic outputs and other things here that would be further down the line from controlled access to data, perhaps. Anyway, let's move on. There's many other questions, and I think Cathie, a good one for you. What are the major barriers to accessing and linking GP data be overcome?
So it's a very good question, one I get asked often. So Datalock do have access to GP data through the Lothian Health Board, through a joint controller agreement with their GPs. That takes a lot of time and effort to maintain, and we worry about it a lot. Our GPs are very close in proximity to patients. They have long-term relationships with patients. They care passionately about protecting and safeguarding patients and patient data. And hence, again, it comes back to, well, how do we understand the requirements from that? How do we respect that and build into our governance frameworks and the relationships we have with the health board and with our GPs to help understand what it is that needs to be true for them to be able to share data safely. And I think the challenge we have in Scotland is that conversation becomes quite local, becomes quite personal when we're trying to do something at scale across Scotland. And that, I think, is the challenge. I think we do need to be having these conversations, and it's difficult and it should take time. And we've taken time to get to the point we're in now. We're almost at a pivot point where we sort of need to say, we've now proved this works, we've proved the trusted relationships, now we get to scale it. Now we have the permission to scale it. But I don't think those conversations with GPs and their communities will stop. I think we need to continue to invest in those. So I think that's the biggest barrier, is it's a relationship barrier and a trust barrier.
It's relationship listening, as you said, and then being able to create solutions that are based on need and the kind of values that underlie that as well. Okay, anyone want to add anything? Cathie?
I think the only thing to add on that is that we can't underestimate the importance of that relationship with professionals, in particular GPs. So, and that's not least because GPs are amongst, and doctors are amongst the most respected of professions across society, and they have a big influence on what patients and the public think. It's sometimes overemphasized, that influence, but it is very strong. And so if GPs feel nervous about something, then their patient, their well-being it. So it is, and it's probably one of the things that has led to some of the challenges in the past. Has been that actually some of the public and patient engagement's been pretty good, but the professionals have been left behind, and there's a bit of catch up going on now in terms of the professional engagement. I think the process of worked very well in Wales and are now working very well in Scotland. Are going to be necessary, and as you say, it's ongoing. It's not, you don't do it once, and then it's you have to keep at it. But we have been too slow. It's been far too slow. So that needs scale, I think, is that sort of at what point is it okay to scale, and how do you continue to then bring the patients, public, and importantly the health professionals with you? I think that's great.
Can I just indulge with it just an extra bit? I do think there is a real value in understanding how this helps GPs understand their own practice areas. So the access to linked data that is linked between primary and secondary care is not something GPs have access to systematically. Again, how do we help them do that? So we've been working with how we can present data back to GPs so that they actually see the value returned, so it becomes a reciprocal relationship, and I think that's important.
Yeah, that's how you build trust and demonstrate the public good, which can apply to the health professionals using the outputs and outcomes as much as the wider public. So a good question here, because we've talked about health relevant data well beyond the healthcare system. So the question is, does the panel have a view on how we can bring care data up to the same level as health data? Because it's an area where we have most to do and where we probably face the most significant challenges, but it's actually also the area where most health work is done actually in the care sector. Chris, I don't know if you want to first stab at that, or
I don't have a lot of experience in this space, so I'm talking from what I've read and what I've heard, so take that with that. The issue, and I think as you touched upon, I think it's a mixed economy in health and in social care. You know, there's private, there's public industry involved in that. So, and there's no overarching system like there is in the NHS, although the NHS is fragmented anyway as well. So, and trying to work with them is going to be like GPs. You're going to have to try and deal with it piecemeal. Each different institute will need a different relationship, and that's a lot of what we do within the Safe Haven network. It's all about building trusted relationships with people, with data controllers and data owners, and that's what we'd have to do again for the social care sector. From what I've heard is that a lot of certainly older social healthcare or social care organizations still work on paper. So I think a lot of work to try and digitize that, and that's where the health informatics started 20 years ago. We digitized scripts for research. That's where we started, data entry and double checking, all that sort of thing. So we might have to do that again for on the social care side. Yeah.
And then Roger.
Yeah, I think that's absolutely right. So the healthcare system is inadequately digitized, and the social care system is super inadequately digitized in general across the whole of the UK. And I think in particular in Scotland in social care, it's a big issue, and it needs investment, but it also needs investment in systems that scale and interoperate well. So one of the big issues in England, where I sort of got up to speed with this, with the rollout of digital systems in secondary care, was that there are several tens of different types of hospital healthcare electronic record systems, and so like most hospitals have one now. That is a lot better than it was before. It's at least got that, but they do not interoperate well. So, and then you've got systems for laboratories and systems for images and systems for pathology and so on. Each hospital and each environment has its own separate systems for each of these. So there is a kind of sort of chaos that makes interoperability incredibly challenging, not under the maintenance contracts for the NHS bodies with all of these organisations. So the one advantage social care has, given that it is not yet really very digitised, is the ability to procure systems well, according to a set of rules, and perhaps what my colleague David Seymour, who I think is in the audience, might call a controlled, not a monopoly, not a duopoly, but a kind of controlled environment of providers, so that you don't have 1,000 flowers blooming, because that will create chaos down the line in terms of uses of the data at scale. And uses of the systems at scale as well. But there's a long way to go with social care systems before you can get the data out of the back end, as it were, to use it wisely.
Roger.
Yeah, I mean, I sort of definitely take all of that. I would say that we're certainly not starting from a really low base. I would say within adult social care, is my understanding. Some data, some relatively basic data has been collected for many years about individuals that are getting different kinds of social care. It has been particularly well used, has been connected to other things, and there haven't been great data standards across the country. So I think that we are in a little bit of a situation you've described, where there's different systems in different parts of Scotland, and that's make it a little bit tricky. But that's changing. I know that from efforts from government, from national services, from Public Health Scotland, they're developing. The data standards are being developed, and this came out of some of the thinking that went to the National Care Service. But I think that there's going to have to be a period where data's not going to be perfect, but we're going to have to start using it. I'm going to have to start exploring its limitations, because that's the only way that the data quality is going to improve. Like Cathie said, getting feedback to people that are actually working in the service is the only way that we're going to get it up to the state that we need it in order to make great decisions about that sector.
Okay, a couple of kind of sort of follow-up questions. So one is about funding. How do you see where the long-term funding will flow for the services provided by the safe havens, or whatever you want to call them? Will it be pay at the point of use by researchers, so therefore then those who are funding research are going to have to pay for that? Will it be funded nationally in some way as part of the critical data infrastructure model? Mixed resources? Obviously there'll be commercial funding in terms of commercial, paying at the point of access kind of thing. How will that all work? Cathie, I think maybe you have to start that one.
Yeah, so I think it's a really brilliant question, and it will evolve over time, and it will continue to be messy for a while, possibly long into the future, I think. So one thing that I think many of us recognise is that traditional research funders have not recognised by and large the need to fund research infrastructures really well that provide services to the research community. And there are people in this audience who are involved in creating and delivering those infrastructures. They're on the panel, but they're also in the audience, and this is very well recognised. So we don't yet have an environment which does that well. I think the welcome in the government, sort of in partnership, stepping up to the plate to fund this entity of the Health Data Research Service, is a very good step in the right direction. It's got a reasonable price tag on it, and that feels like it's got the recognition it needs, although there is a lot of detail in the delivery, and we all know how easy it is for government to waste money on kind of not particularly brilliant direction of spending. So there will be a huge responsibility on those who lead that to ensure it's spent well. I think it will make sense for there to be some kind of core funding for capabilities and infrastructures that's provided through partnerships of major funding organisations, mainly public ones, but possibly also forging partnerships with charities and others. And then the other source of funding, which I think is great for these large-scale endeavours, and I saw it work, which is kind of like maybe a large but yet small-scale population size-wise, of how this type of thing can work. If you build something really great that is attractive to commercial users, you can put together very transparent, above board, pre-competitive consortia to fund infrastructure that is in the public interest to have in place, but which is in the commercial funders' interest to have in place as well. It's a pre-competitive funding model that they've got every interest in making sure it exists. Then if the public benefits off the back of that, they've got interest in that as well. It makes them feel good. It's good for their kind of, public benefit outlook and so on. But it's also great for them as a business. If it's pre-competitive, then you're not doing special deals with lots of different industry collaborators. And I think it makes it much easier to balance concepts or to not have to confront concepts of selling data, which are very unattractive to patients and broader members of the public. So I don't think we've got all the solutions, but there are some great potential ways forward on this one.
And I'm sure engaging with wider public around those solutions, potential solutions, would be a really positive thing to do. I mean, these are complex discussions about the economic modelling for what you're proposing. But I think, just as we've done in the past in terms of discussions around benefit sharing, I think we could do that in this context as well. Cathie, you wanted to? Sorry, everybody wants to come in. Cathie next.
I was just going to say, I'm glad Cathie answered the question on the funding side, but I think we also have an opportunity to think about consolidation and improvement of these services. So that there is a habit, particularly actually with research funding, to build new all the time. But actually, we have an incredible amount of value sat in the services on this panel alone, and in the room in terms of TRE infrastructures. I think there is an opportunity for us to think about how do we improve the user experience by consolidating some of these services, and actually provide us a cost saving in Scotland. So actually we become a much more efficient service with a single point of entry, where actually the money is going where the money can deliver best value. So that is in the data and in the relationships that we have with clinicians in understanding that data, and in the public engagement around the data. And we're not spending duplicate money in building duplicate services. So I think there's a real opportunity. And actually, I think that is an RDS priority. So I'm just being above Roger. Sorry.
No, well, that's perfect, because that's exactly what I was going to say. So thanks, Cathie.
Okay.
Just to put some numbers to it. So we, as a network, we recover 70% of our costs through research grants. So we're a mature environment. We're a mature network in Scotland that has survived and has lasted. More than survived. We've lasted, at least 10 years. Some of us longer than that. So we have mechanisms, and we know the market. We know, to talk, that kind of language. We know how to manage and work with researchers to provide what is required to advance research. So it's not just access to data; it's also services around software tools. It's around databases. It's around questionnaires, those sorts of things. Those are all things that we can provide to research, and we can offer those on a cost recovery basis on grants, and we do that, and we do that very successfully. What we need is, like Cathie was saying, and we talked about for 2 days just last week amongst our network, is some infrastructure funding, as Cathie was saying, just to top that up, so we can do these efficiency gains, so that we can improve the system wholesale, rather than piecemeal through a bit of siphoning off some money off this grant or that grant, or whatever, to just have the people in space. So it doesn't need a lot of money, but it needs to be well targeted, brought together, and over a 2 or 3 year period, we'll be able to solve many problems that way.
Okay, I'm going to link a couple of questions here as we're kind of drawing to a close. So maybe Cathie Sudlow and Roger can take this. So what has been the Scottish Government's response to the review? And if you can say, and also, is there a sense that it is important to have a UK-wide health data resource when health is devolved? So go for it, Roger.
Yeah, well, sorry, second of those questions. Second of those questions, it's really clear, research doesn't stop at the Scottish border, it doesn't stop at the UK border, but having so Scotland playing into and using the fantastic expertise here, the fantastic data that we've got here at the UK level, can I think only be a good thing from my perspective. I'm not speaking for Scottish Government, anymore. I mean, I think that where ministers are on this is that they're just, I guess, waiting to see exactly what comes out of the proposed health data research service. I think what they want is they want to use they share a lot of the common ambitions to get the data that we have here, as we've talked about today, used for the public good. And whether that's through the fantastic work that's already going on here in Scotland and that we've got planned, or whether that's been part of the Health Data Research Service, I suspect they'll want to say something on that publicly very soon.
Yeah, I mean, Roger knows this. So there has been, I haven't personally had conversations or responses from ministers directly. So it's very interesting to hear what Roger's got to say. But we are in a politically quite a tricky time at the moment with an election coming up. So I suspect once a new government is formed and in place, there will be, and the Data Research Service for the UK is up and running, there'll be an opportunity to revisit some of those conversations. But very quickly, actually, after my review was published, Anna Dominicek and her team and some of the people who work in the civil service in government invited me to come and speak to them. And I've had similar invitations and interactions with colleagues in Wales. It's been very rewarding, a really great opportunity to kind of present the UK-wide context and showcase some of the stuff that I was talking about earlier about where particularly smaller devolved nations have a real opportunity to be in a vanguard position. So the UK-wide solution stands to benefit from being UK-wide, but it can derive intelligence from different parts of the system. The regions of England and England as a whole can do exactly the same thing. So I think the advantage in that UK-wide system is the opportunity for joint learning, whilst recognising that there are some intrinsic differences. They can be an inconvenience and they can make life difficult, and sometimes there is a bit of either deliberate or possibly unintentional territorialism around the way these things operate. But I think it's really important that we attempt to rise above that and use this UK-wide notion as an opportunity. The one other point I would make is that there are a large number of questions which cannot be addressed even with a population of 5 million people. So for very rare conditions is one good example where you need bigger. And so not only do we need to, but we need to be ready and willing to work well with partners in Europe and elsewhere across the world in this space. So if we don't have our house in order here, then we will really struggle with those international interactions.
Okay, just one last question. Again, I'm going to combine two. So whoever said Stuart pick me, we've heard you. So, and it's a good question, and particularly a good final question. In answer to the question, I want you to weave AI in, because there's questions about that as well. So what do the panel see as the biggest change that will happen in health data research in Scotland in the next 3 years? You've all got a sentence, so we can start with Roger.
I think we'll have coordinated ourselves to provide researchers with a single route into accessing data across Scotland.
Okay.
I'm hoping we'll see a lot more systems thinking. I'm looking at Julie going on around the idea of the health system and much more research in that space.
I think the ability to link across different domains would be a lot easier. So we can do the whole education, social care, health in one go. I think that would be brilliant if we could do that in 3 years.
So you wanted AI, Sarah. I hope that what we'll see is that we're using AI well. So to automate, to do the stuff that humans find boring. So, we can automate authentic reading of multiple images and deriving variables for analysis. One good example, but there are many others. And automation of curation and routine, repeatable analysis routines is surely a job that we can set AI to, provide a real and it's responsible for really great opportunities. It'd be really, really great to see that happening well in Scotland, and I think we're particularly well positioned
give somebody to join on that one.
Okay, I think a big round of applause for the thank you so much. So much to think about here. So even though the review came up with these very clear sets of recommendations, I think this discussion has demonstrated how much kind of prior and underlying work has to be done, both at the level of the workforce, the kind of infrastructure, but the kind of wider sort of ecosystem, including the kind of economics of it, that has got to be put in place, and how we have to do so much work to make sure we actually have the data that we need. And some of that data is not in any form that is really readable for the kind of data use that is being proposed here. So still so much more to do, but but we're traveling in the right direction. And I hope that you feel that we've discussed both opportunities, benefits and risks here in a way that will help generate a really sort of trustworthy data infrastructures going forwards. Thanks everyone for coming and for all your great questions, and apologies, obviously couldn't get through them all, and a big thank you to Stuart for really helping me here, and so that I could see the questions really well and ask them and meld them together as well as I needed to. A few other thanks before we close and move outside, where there's refreshments and a chance to chat to each other. We have a fantastic Usher comms team here. Laura Marshall, Susan Buckingham, Kitty Flynn, Sarah Murray, Dawn Katanak, Karina Bremer and Joanne Blair-Gray. They're all just wonderful to work with, and Stuart as well for his great support, all of them in the delivery of this event. They've made it really easy for all of us to actually sort of concentrate on the thinking that is required when you put this stuff together. Outside, of course, our caterers, our reception staff, and all of those that keep our building, wonderful as it is, functioning for all the range of functions and events that we have here. You've got the clicker. Good. Too good on the clicker side of this. Before you leave the room, digital or here in person, we would welcome feedback and comments. So do take a few moments if you wish to complete a short evaluation form. And also, if you aren't yet on our mailing list, do sign up. You can get a monthly newsletter, get notifications of our events. This will come back on again in a minute, but I also want to let you know about an upcoming Usher event, which is here, but not in front of me. I do know about it. The Usher Institute annual lecture, which takes place on the 25th of September. So it's a great opportunity to hear David Nash speaking, and also an opportunity to find out more about the amazing research that is being done across the Usher Institute, which will be showcased alongside, well, before and after the lecture, not alongside the lecture. We would give him the platform to do his stuff. So that's it from us. Thanks again, everybody.